But this is our last debate, so we will have the slide first. Here's a 31-year-old female, fall down the stairs after drinking, isolated injury, radial nerve is intact. The patient is left-hand dominant, works part-time in retail. So there's our case. Dr. Brady is going to tell us why we should fix it.
Are we voting first or no?
Oh, I'm sorry. I forgot about that. Let's take a vote. Operative, non-operative. 31-year-old, dominant arm, fell drinking, is working in retail. Operative or non-op? I'm not going to sing, Sue. You just pretend there's some music playing. All right, so it looks like 63% non-operative, 38% operative. Dr. Brady's going to try to change your mind.
Hashtag winning.
Okay, so I'm not going to have a whole lot of primary literature to talk to about this case, but we're a bunch of orthopedic surgeons and we're a bunch of orthopedic residents, and we're learning how to operate on people. I think there is definitely a role for non-operative treatment in many things that we do, but sometimes we're not the bad guys, and actually offering patients operations is actually a good thing to do. I'd like to argue that for humerus shaft fractures, operative care is conservative care. So how I would treat this, this x-ray looks exactly like a patient that I treated about a week ago, same injury. And the treatment I would offer for this is 7 to 10 days of splinting. That's what they get from the emergency department until their first follow-up with you. Take them to the outpatient surgery center or in the hospital outpatient department, regional anesthesia, no post-operative splinting, immediate rigid fixation, immediate shoulder and elbow range of motion, back to work in less than a week, x-rays at 2 weeks and 2 months, and then they're on their way. They may or may not need physical therapy. So why do we think about operative treatment? Predictable union rates with operative treatment, although we can argue that there's predictable union rates with non-operative treatment as well. There is a low incidence of complications, and you might have to just decide what type of complications you're willing to deal with. I would say that most of us surgeons are comfortable dealing with incision site infections and complications such as that, because we can treat those with antibiotics, or we're comfortable doing secondary debridements to fix that problem, but we may not be as comfortable dealing with pressure necrosis issues or ongoing non-union and fracture instability and pain over time. We can limit the need for splinting, casting, or bracing. The patients are absolutely more comfortable. There's less need for the doctor-patient interaction. Not that you don't want to talk to your patients, but I don't want to have to tell my patient, and the patient does not want to have to say, oh, you're going to come see me today, and then I'm going to give you a prescription for a brace, and you're going to go get a brace put on, and then in a week you're going to come back, and then you're going to take an x-ray on the brace, and then we're going to tighten your brace, and then you can't sleep, and then you got to see me in another week because it might start displacing. We want to make sure it doesn't displace, and then at 6 weeks you're going to come back, and I'm going to yank on your fracture under x-ray to see if it moves, and if it moves, then we'll have another discussion about whether we should fix it or not fix it. Why don't we just fix it? Pain control is more reliable and immediate, less risk for unrecognized skin compromise because you're not hiding the incision in a brace. Operative care for humerus fractures is conservative care. So we know that there are acceptable limits of reduction that you can have in humerus fractures. Humerus fracture is near your shoulder. Your shoulder is a very mobile joint, so you can take a lot of deformity. And cosmesis is not necessarily an issue if you have a mal-reduced or a mal-united fracture. However, we know that surgical treatment does give better alignment, and in today's day and age, patients want everything perfect. Range of motion at the elbow is generally not decreased with non-operative treatment of humerus fractures because we can start, and we actually should start, range of motion of the elbow immediately after treating humerus fractures in a fracture brace. However, we should not start shoulder range of motion until we have a fracture which is starting to show some good healing. So ultimately, patients are shown to have less shoulder range of motion in the long run. We all know how to deal with surgical site infections and surgical site complications. That's what we're training to do. We hope we don't see them. We know we're going to see them with any type of surgery we do, but we know how to treat an incision line complication. However, if in 2 weeks when the patient comes back to see you, you see skin that looks like this with pressure necrosis that may or may not go on to full thickness skin loss, and now you've taken a closed fracture and made that an open fracture, which is a relative indication for doing surgery. Do you want to operate through this skin? I would say no, you don't. Do you want to have to involve plastic surgeons in order to help take care of this patient? Patient compliance is an issue. So patients want everything perfect, and they want it perfect right away. They don't want to have to put on a bulky brace. They don't want to have to do office visits every week for the first 3 weeks. They don't want to have to sleep in their recliner because their arm moves every time they lay down. Rates of nonunion are similar, anywhere from 2 to 10% with operative or non-operative treatment. There's a study by Rehman that shows that if you stress your fracture at 6 weeks, motion at the fracture site at 6 weeks predicts non-union. How many people are comfortable taking their patients into the x-ray room just in your office and stressing a fracture to see if there's gross motion at it at 6 weeks? That seems cruel and unusual. And then revision surgery is difficult. So this is an 85-year-old patient who I saw who was treated non-operatively in a humeral fracture brace for 2 years. And finally came in to see me after surgery and said, there is really nothing else we can do. But 2 years later, she has gross motion at her fracture site. She's miserable. She can't move her shoulder. She hasn't moved her shoulder in 2 years, so she's got an extremely stiff shoulder. She's got some rotator cuff arthropathy. And you look at this and you say, that should be a fairly easy fix now. You know, we can take down the non-union and compression plate this. But that's technically difficult to do. If we fix this in the beginning, then we know where all of our neurovascular structures are. We know that whether we go anterior or posterior or lateral, we're going to be able to find the radial nerve. It's not going to be encased in a bunch of scar tissue. When you're doing this a year later or 2 years later trying to treat a symptomatic non-union, then you don't know where your radial nerve is. You don't know if it's encased in scar tissue. You're really hesitant when you're doing your operative takedown of this non-union. You can do it, but it's hard to do. Why don't we just do this in the beginning? I think the patients would be much more happy. So surgery for humerus fractures, in my opinion, is conservative care. And that's what we're always taught to do, offer the conservative option first. However, surgery must be done correctly. We have to adhere to appropriate fracture fixation principles so that we do not create our own non-unions and soft tissue problems. So if you have short segment fractures, then you need to do lag screw and compression plating. If you have long segment fractures or more comminuted injuries, then you need long constructs in a low strain environment. So this is an issue where there's a comminuted fracture treated with a short segment internal fixation on the medial side that the plate was put. Predictably, that's going to fail because the principles were not followed. But if we follow the principles, reduce the fracture, get some interfragmentary lag screws, and bridge and span the most areas of comminution, then we can get predictable healing. Operative care of humerus fractures is conservative care. If patients are more comfortable, we're going to get more predictable healing with better alignment and range of motion, which is what we ultimately want. We want the best outcome for our patients. You get predictable healing. You limit the fracture disease of osteopenia from disuse, from stiffness and skin compromise, from putting a brace on and squeezing it for 6 to 12 weeks. Surgical complications can be eliminated or limited with meticulous surgery. And if you're not comfortable with this conservative measure, then I would say refer it out to someone who is, but you are still acting in a conservative manner by treating your humerus fracture patients with surgery. Thank you.
Thanks, everyone, for sticking around. We still have a good crowd on a Saturday morning. And Saqib for keeping things going for 10 years. Without a doubt, he's also put me in, thank you. But other commenters made a choice. If we get, not stuck, assigned a topic where takes you out of your element. And I think somebody mentioned a suggestion in 2016 to have debates, because I was intrigued with this whole political thing going on in 2016. That was me. And here I am. We're doing debates. All right. I'm in charge with the debate of the humerus fractures. Here's our 31-year-old female with a fall downstairs after drinking. Isolated injury. Isolated injury. I would describe this as a low-end injury. It's not a fall from a significant height. It's not a motor vehicle accident. Radial nerve is intact. Described as a left-hand dominant female working part-time in retail. I'm Dr. Craig. So I was looking at this and thinking to myself, well, you know, we're looking at an x-ray. this is a 31-year-old female, and I'm married with kids, and I don't really know a lot of 31-year-old females, so I Googled, who's a 31-year-old female? So this is LL, works part-time, pretty much, and publicly available date of birth is 7/2/1986, with this left arm closed, neurovascularly intact injury. If you want to code it, it is either non-displaced spiral fracture of the shaft of the humerus, left arm initial counter for fracture when you see her in the office. When I look at this, we are describing as the dominant arm. I don't think that plays a role in my discussion of like, oh my gosh, it's your dominant arm, you have to fix it. And I'd say, no, it's your dominant arm, we can overcome that. I right-handed, I throw left-handed, I can use both hands. It's well aligned, certainly within acceptable limits, which were discussed. I'll bring that up as well. Arm appears not large, right, in this circumstance. I put the orange line there because that's where my brace, that's the upper limit of a brace that's going to go on. That's where I kind of look at these fractures. Can I brace this fracture? This is the case we're being presented. Radial nerve is intact. People argue like, oh, the radial nerve is out, you have to explore it. This is not this case. This radial nerve is intact. This whole case here appears amenable to bracing. If we look at the whole situation here, going through some epidemiology, what do we do with non-operative treatment, and so forth. Epidemiology, it's interesting. This came out in 2006, I believe, from Stockholm. They keep track of their patients. The majority of these are going to be female. Interestingly, the majority, 52%, are on the left side. Simple falls. This is our patient. Unlikely to be open. And an 8.5% radial nerve palsy. Again, not our patient, but this is a low energy fall, female, on the left side, very common injury to occur. Anyone who can sit upright, we're all a bit of bipeds, we stand and sit all the time. And you can maintain a semi-upright position during early treatment phase, you can have a brace or a splint applied. It's a closed fracture, isolated fracture. So is cosmesis important? Well, how big do you want the incision to be? Or as Dr. Fuller put it, like nobody really should want surgery. So in this patient who's going to consider, further part-time work down the road, maybe they don't want a big incision on their arm. And the arm is thought to accommodate these degrees of angulation and displacement. There's not a randomized prospective trial that's going to show you, well, we're going to randomize everyone to 1 centimeter, 2 centimeters, and 3 centimeters displacement and find out what happens. This is all just a retrospective analysis, 50 years ago, looking at, well, how much they accept and how much did I think, because some things were more dogmatic back in the 60s, and it worked. But we've seen this in practice. Treat them closed, they go on to heal. People accept a mild deformity radiographically within their arm, but clinically and functionally doesn't lead to very much. Really, it's simple. You let it hang down. There's not much of a reduction that it needs to be performed. It would not take someone to the OR to manipulate them for a closed treatment. You can use this fracture brace. It's commonly available through many companies. Apply acutely or later on. I put a splint on in the ER, have some compression applied. There can be an issue of like, where do you get it? Yeah, you can give somebody a prescription. They can go to a surgical supply store. You can order them online. If you put it into Amazon, humerus fracture brace, you can go buy one. They're not that hard to find. And then applying a sling initially. Maintaining an upright posture. We are bipeds. That's okay. Give them a sling, allowing the arm to hang down. Close follow-up is important. You're a doctor. They're your patients. You have to see them back. Yes, that I do agree. 1, 2, 4, 6 weeks later, following along the fracture healing and brace compliance. 3 months, 6 months. I think that's fairly routine. I have been quoted, I have my little quotes, fix and forget. I love that. But in this patient, closed injury, isolated arm, there's no indication for operative treatment. And assessing for fracture motion. I brace until they're healed. I'm weaning from the brace at about 10 to 12 weeks. I think this is the article that was discussed by Dr. Brady, Dr. Driesman, Dr. Eagle was here yesterday. Really, they're looking at 315 humerus shaft fracture patients, 84 all treated initially non-operatively, 73 out of 84, 87% all went on to healing. At 6 weeks is that key point. Treat them non-operatively, see them back at your interval times. You can even tell them in the beginning, we're going to treat you non-operatively, and which I would describe as conservative treatment, by the way. And if you have callus and no motion at 6 weeks, and that's not in the radiology suite, that's just physically examining them. The case that he presented of that 2 years of nonunion, that lady is going to be grossly unstable when you examine her. Not really painfully, but grossly unstable. At 6 weeks, callus, no motion. They're going to go to union, no callus, no motion. Then I have the discussion of surgical treatment. Initial and pendulum of the shoulder, elbow and shoulder stiffness in these injuries when treated non-operatively is an issue. People do come to see me with their non-operative treatment going on to a non-union. They're very stiff. I think non-operative treatment is not no treatment. Non-operative treatment is a non-operative treatment modality, which you have to then treat their elbow and shoulder stiffness proactively. So doing pendulum exercises, elbow range of motion exercises, they are non-weight bearing. It's an isolated injury. If they have a femur fracture, things like that, that's another discussion. But doing active shoulder exercises when the fracture is stable, I send them out to therapy if they desire it after 6 weeks. Just an example, these fractures go on to union. It does work. Here's an example of mine. This was even, I would describe the angulation initially is not all that great. Once the splint goes on, that's improved. Then with the later x-rays, I like to get an x-ray in the brace here. What you're going to see here is the extent of the brace perfectly centered over the mid portion of the fracture. So I know that brace is going to support the fracture as necessary. They're able to get their elbow and shoulder moving. We've all learned this from Dr. Sarmiento. He had his large series of patients. It was the most recent publication is 2000, but large series of patients, some of them even open, with a 6% non-union rate, mostly in the open fractures, but less than 2% in closed fractures, and accepting some angulation, and the outcomes are very good. Even radial nerve palsy is resolved. So we've talked about lots of randomized prospective trials. There is not a randomized prospective trial that's been adequately studied to help us out here. For whatever reason, the clavicle is immensely studied, but yet the humerus is not. So the Cochrane review said there's no evidence available for randomized controlled trials, even though there is some, to ascertain whether surgical intervention in femoral shaft fractures is better or worse than no surgery. So whether they're going to call something conservative or not, I don't think we're there yet. Rather than engaging in a surgery that may be unnecessary, beginning with non-operative treatment, converting when necessary. Why would you do it? All right, vascular injury, floating elbow, additional element, segmental injuries, failing your closed reduction, bilateral fractures, open pathologic. That's not who we're talking about. This is this closed, left-hand dominant, 31-year-old female, neurologically intact. Polytrauma with the humerus fracture, I fix a lot of humerus fractures, but in this patient, that's not what I would support. Bracing is the standard, right? That's what we do. That's what I would describe as conservative treatment. But there are fracture considerations, patient considerations, discussing the options with your patient, remembering who your patient is. This may be not something that you may be desiring of that, the rep may be desiring of that, but for the patient, that's not what's necessary. When you go on to operate, yeah, you're going to have non-unions, you're going to have infections, you're going to have radial nerve palsies. Is that what you want? You've made them worse, right? You started out with a, mildly displaced, if you will, fracture, but now there's an infection and a radial nerve palsy. You've made somebody worse with surgery. There's no as somebody pointed out, nobody can be made worse, or can't be made worse with surgery. Here's an example of somebody who came in the morning with a displaced humerus fracture, and then somebody decided, well, let's just fix it that night. We're going to put in a nail, nice and short. Nothing can't be made better with a nail, right? Well, that predictably fell apart, and then the non-union had been sent to me as shown in that prior x-ray. So remember, brace you can brace. There's a lot of people you can brace. We don't need to jump to surgery. These are usually lower energy, isolated injuries, acceptably aligned. You maintain the alignment of brace. Get the fracture to move as a unit at 6 weeks. You know who's going to heal. Get the arm moving to avoid stiffness, and then follow them closely. Thank you.
All right, thanks. So can show the slide real quick. I did post a lot of your guys' papers on the orthoclips.com/10th website. So if any of you want to refer back to that literature that was cited, you can take a look. All right, so I think you saw this multiple times now. Let's vote. I think it was 63% non-operative before. Sorry, okay, start now. I did not hear that Dr. Sarmiento broke his humerus.
God bless him, broke his humerus and lasted 1 week before he had an operation.
Well, we had Dr. Sarmiento here about 5 years ago. Wish we could maybe have him weigh in on the debate. But it seems that
What happened to Sean Nork?
non-operative.
That is not urban legend. That is true.